Otherwise, we'll kickstart the session today. Okay, so we've got Razor, who's our lovely junior ophthalmology fellow who's based at Sussex Eye. Okay,
Hello.
She's spending a lot of her time under the oculoplastics team as well as a few of the other teams, learning a bit more about ophthalmology and spending a lot of her time doing various projects. So Razor, I'll leave it to you to introduce everyone to this lovely topic.
Hello everyone, thanks for coming back. It's a pleasure to be with you all today. We're going to be talking about some neuro-ophthalmology and discussing some key topics. I'll do my best to answer any questions that you have as we go along the way, and feel free to chime in whenever anything doesn't make sense. I've done my best to make it sort of easy and digestible, I hope. But Yarrow will be here to help if there's anything I can't sort of answer or make clear. So these are our learning outcomes for today. We'll be talking about pupillary reactions, the optic nerve, its anatomy and its implications in disease, cranial nerve palsies, and we'll talk a little bit about diplopia, and I'll take you through a way to sort of think about that when a patient presents with it. Okay. Sorry, PowerPoint's not moving. There we go. Okay, so for those of you who joined us before, you'll remember that we, in our physiology lecture, spoke about the parasympathetic supply to the eye, and that the sphincter pupillae, the muscles which cause constriction of the pupil, are under parasympathetic sort of control. So as those contract, it will reduce the size of the pupil. With the sympathetic response, the dilator pupillae, or these radial longitudinal muscles, they'll contract and the pupil will increase in size. And we'll talk a bit more in detail about the mechanisms underlying that pathway. But just to start off with some basics, I'm sure you all know already, but light directed at the pupil should produce a bilateral symmetrical pupillary response, specifically pupillary constriction, and that response should be direct and consensual. So each pupil receives parasympathetic and sympathetic input at any one moment, and it's a balance between the sympathetic and parasympathetic tone which influences the size of the pupil. So it's a balance also between those two opposing muscle groups, the dilator pupillae and the sphincter pupillae. So when you're presented with a patient to have a look at your direct response, you will shine the torch ophthalmoscope into one eye, and the direct response is the constriction of that pupil. At the same time, the contralateral eye should also constrict, and that's the consensual response. You can see by the diagram. And that's the normal response. Another thing that you would want to include in your examination when looking at a patient for the first time, you want to know the size of the pupil in your document, right and left. Normal pupil size is about 2 to 4 millimeters. You'll also look for any anisocoria, so that would be any sort of difference in size between the pupils, any asymmetry. 20% of the population can have physiological asymmetry. It's completely normal, it's completely benign, and generally in these cases, the difference will be less than 0.5 millimeters, and the difference in the asymmetry of the pupils in light and in dark will be the same, so it won't change. You'll also document the direct and consensual light response. You'll look to see if there's any relative afferent pupillary defect, or RAPD, which we will be talking about a bit later. You'll want to assess the dilation of the pupil in a dark room, and that's because if there's any asymmetry, you want to make sure that it stays the same, that difference is the same in light and in the dark. And you'll also test the accommodation response, which we talked about in the physiology lecture. Okay, so this is what we talked about last time. We talked about the parasympathetic innervation, which causes pupillary constriction. And what we said was that there would be a light response, which is picked up by the retina. It travels down the optic nerve to synapse in eventually the Edinger-Westphal nucleus. And then from here, the signal travels down the parasympathetic fibers which go along with cranial nerve 3 to then synapse in the ciliary ganglion. The short ciliary nerve then innervates the sphincter pupillae and causes constriction of the pupil. And we'll talk about this in a bit more detail, specifically regarding the nuclear connections. Okay. So we're going to talk about what causes the direct and consensual response. So as you can see here, get my pointer up. You've got a light stimulus, which is hitting the temporal side of the retina. So we've got the temporal side here. I'm just going to annotate for you quickly. Okay. So we've got the temporal side and the nasal side. Light hitting the temporal side of the retina is going to travel down the ipsilateral optic nerve. It's going to travel all the way down and synapse in the pretectal nucleus here. So this is a nucleus we didn't talk about last time. Now, the pretectal nucleus connects to the Edinger-Westphal nucleus on the same side and on the contralateral side. So by doing that, one light stimulus evokes a bilateral response because you're innervating the ipsilateral side and the contralateral side. So from the pretectal nucleus, you innervate both Edinger-Westphal nucleus. From there, the parasympathetic fibers travel in the inferior division of cranial nerve 3, synapse in the ciliary ganglion, and innervate the sphincter pupillae. Now, just as like a worked example, if you think about the light response coming to the nasal retinal field, it's going to travel all the way down. It's going to decussate in the optic chiasm. Similarly, it will connect in the pretectal nucleus and join both Edinger-Westphal nucleus so that you get a response in both eyes. Does that make sense? Hopefully that makes sense. So light stimulus to retina, optic nerve, pretectal nucleus, innervates both Edinger-Westphal nucleus. Parasympathetic nerve fibers travel in the inferior division of cranial nerve 3, synapse in the ciliary ganglion, and the short ciliary nerve will innervate the sphincter pupillae. And that's what causes your direct and consensual response. Yeah, so the consensual response occurs because each pretectal nucleus is connected to both Edinger-Westphal nuclei. Okay, so we didn't talk about this last time. So this is what causes pupil dilation, and this is under the sympathetic response nervous system. So you've got your first order neuron, or your central neuron, and that starts up here, so in the posterior part of the hypothalamus. The neuron's going to descend down the ipsilateral side of the posterior hypothalamus. And what it will do is it will synapse in what we call the ciliospinal center of Budge, which is C8 to T1 or T2. That's where it will synapse. And that's your central neuron. So now your preganglionic neuron, your second order neuron, that's before it synapses in the superior cervical ganglion. It's going to cross the spinal cord and it's going to follow a really long course, and this specific neuron has quite close relation to the apical pleura of the lungs, and that's quite important because if a patient has Pancoast tumour, that can interrupt the sympathetic nerve supply and give you your classic Horner syndrome. So from the ciliospinal centre of Budge, we cross the spinal cord, we course up to synapse in the superior cervical ganglion, and that's located near the angle of your mandible and at the bifurcation of the common carotid. From there, your postganglionic neuron, or your third order neuron, is going to travel up the plexus around the internal carotid artery. It's then going to enter the skull, and here it will course into the cavernous sinus and will join the ophthalmic division of the trigeminal nerve, from where it will enter the orbit. Sympathetic nerve fibers will reach the dilated pupillae via the nasociliary nerve and the long ciliary nerve. And they will innervate the dilator pupillae to enlarge the pupil, essentially. So you've got three neurons: central, preganglionic, postganglionic. And I've put two little stethoscopes here because we'll discuss the clinical implications of why the location of these neurons is so important a little bit later. Okay. So we'll move on to pupillary defects now. The first one that we'll talk about is an absolute afferent pupillary defect. And that's when you've got a complete neat lesion of the optic nerve. So you've got sort of nothing coming through there. And that pupil will have no light perception. It will be blind. However, when you're looking at a patient in a room who's got a complete optic nerve lesion, their pupils will be the same size when you're examining them. That's because you've still got innervation through this eye, which, as we said earlier, is going to give you connections to both Edinger-Westphal nucleus and produce the same response in this eye. So when you shine it into the good eye, so here, there'll be a response in the affected eye. But when you're shining your ophthalmoscope into the affected eye, it's not going to produce any response whatsoever. And that's otherwise known as an amerotic pupil. I don't think anyone ever uses these terms anymore. I've not heard it, but they love it for exams. They love it. I don't know why they won't let it go, but there we are. Okay, now we'll talk about RAPD. So this is where you've got an incomplete optic nerve lesion. So the connections aren't completely severed, or it can be due to very severe retinal disease, but it's never due to a dense cataract. Okay, you're going to diagnose it using the swinging light test, which you've probably all been taught already. And I'll show you a quick video now, because once you see it, you can't forget it. I just got to work out how to share the video. Hold on. Can you see that YouTube video? Is it coming up for you? Can you see two eyeballs? Yeah, okay, cool. Okay, so this guy's going to hold up some pieces of paper and stuff in front of one of the eyes. Just ignore it. I'm going to tell you what you're looking for first. If you can see my pointer, this is the affected eye. So this is the eye with the RAPD. He's going to swing the light into the normal eye first, which is what you should do, and you'll see that this pupil constricts. Similarly, this one does. Constrict when he shines that light. Now he's moved the light to the affected eye, and what you'll notice is that this eye dilates, whereas it should remain constricted. So it dilates, as does this one, and then he moves it back across. And you can just see how it constricts, dilates, an affected eye, and that's what you're looking for with an RAPD. Okay, and again, at rest, an RAPD won't cause an anoscoria, and they'll be the same size at rest because you've got that bilateral input. Yeah, so pupils are the same size if you've got afferent lesions. So if we go back to, so if you've got anything up until this point, which is a lesion, your pupils will be the same size. After that, so from this point onwards, if there's any lesion, it will cause the pupils to be a different size. So postganglionic, and anything to do with the iris, maybe synechia, which we've talked about before, or if there's any problems with the pupillary muscles themselves, that can cause an anisocoria. So there's lots of differentials for an RAPD, and as Yarrow told us last week, the best thing to do is take a really thorough history and your examination will be extremely important, because the list is endless. So being aware of things which can cause an RAPD are really important, but what will really direct you to the cause is the history you take from the patient and the systems history that you do. So in the exam, when you've got a case vignette and they're describing what the patient has, just really look for key past medical history that could point you into the direction of what causes an RAPD. But a simple way you can kind of break it down is you can think about the optic nerve having problems. So that would be things like optic neuritis, which we'll talk about in a couple of slides. And there can be infectious causes or demyelinating causes. MS is the really big one, or orbital disease. So we've mentioned so many times thyroid eye disease, love thyroid eye disease, that can cause optic neuritis. Sarcoid, if you've got deposition, granuloma deposition within the orbit, affecting the optic nerve, or tumours which might be compressing the optic nerve, whether they're benign, whether they're malignant, that can cause an RAPD. Drugs, the big ones, ethambutol, which is typically used for TB, or methanol. Another one is amiodarone, or alcohol even as well. You can have ischemic optic neuropathy, which we'll talk about in more detail later on. Glaucoma, if it's unilateral and if it's severe, that can give you an RAPD. Trauma, so if someone's had surgery, we mentioned before that you can have retrobulbar anesthesia, and that carries a risk of damage to the optic nerve. If someone's had a head injury, perhaps they've got a fracture compressing the nerve, perhaps they've got retrobulbar hemorrhage, or if someone's being treated for cancer and they've had radiotherapy, that can damage the nerve as well. And then, as always, you've got your congenital causes, a big one being Leber's optic neuropathy. So you can also think about it in terms of retinal disease. Now, if it's going to be a retinal cause, usually it has to be very severe and it has to be asymmetrical as well. So ischemic retinal disease. Now, I highlighted ischemic in yellow because there's this idea that there's ischemic retinal disease and non-ischemic retinal disease. The non-ischemic is relatively benign. It's not going to cause severe loss of eyesight. You might get some cystoid macular edema and maybe a central scotoma, but that's it. With ischemic retinal disease, you've got the very high risk of growing new blood vessels, so neovascularization, and the bleeds from that can cause significant damage to eyesight. So that's why it has to be ischemic retinal disease. Retinal detachment as well can cause an RAPD, or severe macular degeneration, but again it would have to be unilateral and more severe on that side. Tumours, melanoma, retinoblastoma, and any sort of metastatic lesions if they're severe. And then the retinal infections like CMV or herpes simplex or toxoplasmosis. Okay, so we'll move on to light-near dissociation now. So this is when the light reflex is absent or sluggish, but the near response or accommodation is normal. And this is where we'll cover some of those weird named pupils that exams love you to remember. So light-near dissociation, the light reflex is absent or sluggish, but accommodation is normal. They can be separated into bilateral and unilateral causes. So the bilateral cause, you've got an Argyll-Robertson pupil. Now you can remember this by using this kind of a mnemonic, kind of accommodation reflex present, pupillary reflex absent. So you've got ARP and then PRA backwards, and that can sort of help you remember. I wish I came up with that, I didn't, but it helped me to always remember what that pupil means because I always forgot. But it's generally caused by neurosyphilis, and you'll find that the patient has very small, irregular pupils, and these pupils will be very, very hard to dilate, or they won't react at all, but they will react very quickly to accommodation. Yeah, and we've got other causes like encephalitis, type 1 diabetes, myotonic dystrophy. Yeah, why dense cataract doesn't cause an RAPD? I think because the dense cataract will never be as so bad that you won't get any light passing through to your retina. I can't find it written down exactly why, but I don't think anyone's cataract would be so bad that it stops any light response coming through that you would get an RAPD. That's my feeling, but I don't know, Mary Yarrow could do some like searching whilst we're talking. But yeah, that's what I came to understand, but I did try and look, but I couldn't find it anywhere. Oh, I'll do. Cool. Okay, so that's that weird pupil. Okay, and then like I said, the unilateral causes. Thanks, Asta. There we go. So unilateral causes, we're thinking about a Holmes-Addy pupil. So you've got denervation to the postganglionic supply to the sphincter pupillae and ciliary body, and it usually follows a viral illness. It's unilateral in 80% of cases, and you'll find that someone has a large regular pupil, and you can see from the diagram, the pupil that I'm circling now is the affected one. When you direct light at it, it's very, very slow to constrict. When you do accommodation, it will react to accommodation. The near response will be normal, but it will be slow to constrict. When you take away that near response, it will be slow to dilate. So you can see here that the normal pupil has dilated, but the Addy's pupil is taking its time. So unilateral causes, Addy's pupil, and also an afferent. Oh, sorry, Yasmin. Do you want me to repeat anything? I can go back, it's fine. Do you want me to go back at all? Feel free to type in the chat or I'll just carry on. Okay, I'll carry on, but if you want me to... Oh, no worries, don't worry. So am I. It's okay. I'll slow down. Right, so Horner syndrome. So I'm sure you all know what's involved with Horner syndrome. This patient has a slight ptosis. He doesn't have a complete ptosis because it's only Muller's muscle that's being affected. So the sympathetic nerve supply to Muller's muscle has been stopped and he's got a partial ptosis. If he had a full ptosis, you would expect, well, you'd be thinking about a third nerve palsy. So you get partial ptosis. You can see that his pupil here is constricted, so he's got meiosis. And another feature of Horner syndrome is anhidrosis, so the loss of ipsilateral facial sting. Now, the causes of Horner syndrome, we can differentiate that depending on where in the sympathetic chain we've got that interruption. And we'll talk about some of the causes. Let's see. Okay. Stem disease. So we said earlier that the first order neuron, the central neuron, travels down the posterior hypothalamus down into the spinal cord to synapse at C8 T1 T2, otherwise known as the ciliospinal center of Budge. So any sort of brain stem disease, whether it be vascular disease or a tumor, could cause interruption in the sympathetic nerve supply. If you have a spinal cord cyst, it's like a fluid syringomyelia or cervical syrinx, it's otherwise known as, and that can extend down the spinal cord. That fluid-filled cavity just grows and grows and grows and can interrupt the sympathetic nerve supply. Now, number 2, we talked about Pancoast tumor. So if we go back to our diagram, we've got that second order neuron which has a really long course and travels up past the apical pleura of the lungs, so it can be interrupted by the Pancoast tumor. It also travels very near the carotid artery, so any dissection or aneurysm there can compress the neuron and interrupt the sympathetic supply. Any glands within the neck which become swollen, so if someone's got lymphoma or has an infection, that can compress the glands, that can compress the neuron as well. And then our third order neuron, so we said that travels up past the internal carotid artery into the skull and cavernous sinus. So internal carotid artery dissection, that can affect the neuron. Any mass within the cavernous sinus, and we'll go through the anatomy in a little while, that can interrupt the supply. It could be a tumour, it could be a granuloma, it could be an aneurysm. Otitis media, there have been also case reports that an infection of your middle ear can interrupt the sympathetic nerve supply. Some people have said it's because the infection disseminates along the lymphatics that way. Others have postulated that it's to do with the connection between the sympathetic supply in the ear and by the internal carotid artery. Nasal pharyngeal tumours and cluster headaches as well. Okay, and that's just repeating what we've said a little bit earlier. Okay, so when you've got your patient coming to you with a Horner syndrome and you want to test it, you can use cocaine 4% drops, and you can put those into both eyes. So we can see here that the patient has Horner syndrome, it looks like, in the left eye. She's got a degree of ptosis there. She's got constricted pupil as well. So you pop 4% cocaine drops into both eyes. And what you see after about 30 minutes is that the pupil doesn't dilate. The normal pupil has dilated, but in the affected eye, the pupil remains constricted. Now, cocaine, it blocks the reuptake of noradrenaline. So if you remember from the last lecture, the main sympathetic nerve supply neurotransmitter is noradrenaline or adrenaline. In the normal eye, all the fibers are working, all the nerves are working normally. So they're producing noradrenaline, and cocaine stops that noradrenaline from being taken up and broken down. So you get a buildup of noradrenaline in the synapse, which causes a dilation of the pupil because you're perpetuating that sympathetic response. But in an eye with Horner syndrome, the neurons aren't producing any noradrenaline because the activity of the neurons has been cut, essentially. So when you apply cocaine into the affected eye, there's no noradrenaline to build up in the synapse. There's no noradrenaline to cause a sympathetic response and a dilation of the pupil, so it remains constricted. I hope that makes sense. Okay, so we've talked about the direct pupil response, the consensual response, the importance of the pretectal and Edinger-Westphal nuclei. We said what an RAPD is and how you would diagnose it. We've also briefly mentioned the causes of an RAPD from retinal and optic nerve disease. We've talked about light-near dissociation and how that corresponds to an Addy's pupil and an Argyll-Robertson pupil. And we've also covered Horner syndrome and the causes, which can be in the central neuron, the second-order neuron, or the postganglionic third neuron, and the tests for that. Okay, so we'll move on now to the optic nerve. We'll have a chat about its anatomy, its subdivisions, and its implication in disease as well. So, I don't know why they like to quiz you on this, but they do. So you've got your intraocular part, which is basically from the optic disc to the nerve head, and it's the shortest part. It's only 1 millimeter. You've then got your intraorbital part here, so that's going from the nerve head all the way through to the optic foramen there, and that's about 25 to 30 millimeters. And within the orbit, this part of the nerve is quite nice and slack. It lies in shape, and that allows it to have some give when the eyes are moving from side to side, so it doesn't stretch the nerve too much. The intracranial part is 6 millimeters, and that's referring to the part of the optic nerve that travels through the optic canal. Now, at this part, the optic canal, you've got the annulus of Zinn kind of sitting around it. So if you see the diagram on the side, this annulus of Zinn is surrounding the optic canal, where you've got the optic nerve and the ophthalmic artery. Now, the nerve sheath surrounding this nerve is partially attached to the annulus of Zinn as well. So if you've got any inflammation of this nerve sheath, when you move the eyes, you'll be stretching the nerve sheath, which is why people can complain of pain, worse, or movement when they have got optic neuritis or any type of inflammation of the optic nerve. Now, the intracranial part, that travels through and joins the chiasm, and that's 5 millimeters to 6 millimeters, 16 millimeters. And the longer the nerve, the more prone to damage it is. So if you've got swelling within the brain, it's more easily compressed. So when you're going to see a patient and you want to test for signs of optic nerve dysfunction, there are lots of different things that you can look at. So reduced visual acuity, which is just your standard Snellen chart. You'll check for an RAPD, which we talked about earlier. And one of the really important ones is testing their colour vision, and you can use Ishihara plates to do that. Sometimes the very first sign of optic nerve disease is dyschromatopsia. Someone could come to you with perhaps normal visual acuity or very, very mildly reduced visual acuity, but they can have massive impairment of colour vision. So it's a really important test not to miss. Another one is diminished light brightness sensitivity. So what you'll do is you'll shine an ophthalmoscope into the normal eye and then shine it into the affected eye. You'll ask the patient which eye was it brightest in? Is it the same in both eyes? And well, if they've got diminished light brightness sensitivity, they will report that the light isn't as bright in the eye that's affected. Now, diminished contrast sensitivity, you can test using Pelley-Robinson chart, and I've got a picture of the chart here. So you'll just ask the patient to read down the list of letters, and it gets increasingly hard for them to do so. And then the last thing you can get them to have perimetry tests for this is a visual field defect. And the visual field defect will depend on how much and what part of the optic nerve is affected. So is it the temporal side? Is it the nasal side? So optic atrophy is the end stage of a disease process. It's generally a sign of advanced optic nerve disease. So on the right side, you've got what we'd say is a normal optic disc. So you've got very, very lovely clear vessels. The disc is a nice colour, and the disc margins are very clear. In an eye with optic atrophy, you've got a very sort of dirty grey disc. You could probably convince yourselves that the disc margins are they usually are, and the pores on top of the disc become harder to make. They're not as clear. So optic atrophy, you've got a dirty sort of dusky disc with optic disc margins which aren't very clear. And optic atrophy can be primary or it can be secondary. I've just been told my internet connection is unstable. Can you all still hear me? Okay, I'm going to take that as a yes. Okay, so you can have primary optic atrophy, and this can be due to causes like tumours. It can be hereditary, so Leber's optic neuropathy we talked about earlier. Okay, sorry about that, guys. It can also be due to retrobulbar neuritis. Retrobulbar neuritis is inflammation of the optic nerve at the back of the eye. That can cause primary optic atrophy. You can also get nutritional deficiencies which cause it, which are a lot less common in this country. That would be like B12 and folate. And then you've got your toxins like amiodarone, ethambutol. Secondary optic atrophy occurs when you've got swelling of the disc head before the atrophy occurs. So that would be things like chronic papilloedema. So an optic disc that's been swollen for a long, long time, and then the nerve fibers die and you get optic atrophy. Other causes, which we'll talk about in a second, include ischemic optic neuropathy. That would be your classic vascular path, a man who has diabetes, hypertension, and high cholesterol, who's got sort of blood flow supply problems to the eye. And you've got papillitis as well. Now, papillitis refers to inflammation of the optic nerve head itself. So optic neuritis, this is a really good way of dividing it into causes. So your demyelinating causes, the most common cause is multiple sclerosis. The typical picture is maybe a 25 to 35-year-old female coming to you saying that she's had on and off changes in her vision. The last episode was 6 months ago and it resolved by itself, and they keep coming and going. And you might find that she has a history of dropping things. You'll do an MRI, she'll have plaques in the brain, and she'll have a diagnosis of multiple sclerosis. And optic neuritis is very closely linked with MS. And that's your most common cause. Then you've got parainfectious, so that follows a viral infection or even an immunization. Typically that presents with very sudden acute vision loss, which occurs 1 to 3 weeks after the viral infection or after the vaccine. Then you've got infectious causes, the big ones being Lyme disease, meningitis, syphilis, or cat scratch fever. And lastly, you've got your autoimmune causes. So that could be associated with lupus or with sarcoid or thyroid eye disease. And the optic discs that you see from your examination can really differ depending on what the cause is. So in someone who's got neuroretinitis, possibly caused by cat scratch fever, what you'll see is generally, it's quite rare, but you can see a lovely macular star, and that's because you've got hard exudates forming where the macula is. You've got inflammation of the neuroretinal layer. If you've got something like retrobulbar neuritis, that typically presents with a normal optic disc, so you might not even see that there's a problem on your examination. Papillitis, which we talked about earlier, which is inflammation of the optic nerve head itself, can present like this bottom picture. So you've got some flame hemorrhages, you've got hyperemia of the disc, you've got a very, very elevated disc, which looks quite swollen. So the presentation can be extremely different depending on what the cause is. We'll now move on to talk about a little bit about non-arteritic optic neuropathy. So that's when you're thinking about your typical vascular path patient. So the man with diabetes who's got hypertension and hypercholesterolemia, you get a total or partial infarction of the optic nerve head, and that's because you get an interruption to the blood supply of the optic nerve via the short posterior ciliary arteries. You want to really optimize their risk factors, and I know Yarrow gave us a nice talk about how to do this. So you'll send off an HbA1c, you'll do a lipid profile. If it's appropriate, you can do a thrombophilia screen, so testing for antiphospholipid syndrome. And you could think about managing their risk factors. So if there's someone who's got peripheral vascular disease, aspirin or clopidogrel can help minimize further progression of the disease, because at least 50% of these patients who present with a problem in one eye will go on to have further problems in the other. So it's extremely important to get the message over to them that controlling these systemic predispositions will really influence their prognosis. And generally, the patient will present with a very sudden, painless monocular visual loss. Non-arteritic, now we're moving on to the arteritic optic neuropathy. So this is classically referring to giant cell arteritis, or what we all know as temporal arteritis. This vasculitis, it likes to pinpoint the medium or large size vessels. So it loves the temporal artery, the ophthalmic artery, and part of the posterior vertebral artery, but it will spare the smaller intracranial vessels. Now, GCA is a medical emergency because it can cause blindness, essentially. The patient may come in complaining of jaw claudication or scalp tenderness. Generally, temporal arteritis or GCA is very closely associated with polymyalgia rheumatica. So the typical case vignette in the exams is a 60-year-old lady who's complaining of pain in her shoulders and her hips, who's more tired all the time, and that's meant to be telling you she's got PMR. So that's pointing in the direction of perhaps she's got temporal arteritis. And when a patient comes in with this, you'll send off an ESR and a CRP. Generally, the ESR will be extremely raised, and you'll want to start them on high-dose steroids, and usually that's about 60 milligrams. So you'll start them on that, and you'll want to refer them to ophthalmology because they will need a temporal artery biopsy. Now, in all the textbooks, it says it has to happen within 2 days, but in real life, it's not really happening until 2 weeks later, and that's the clinical time frame that we give patients. Within 2 weeks, they need a temporal artery biopsy. Within 2 weeks of starting steroids, that is. And you're only really doing the biopsies that you can look for histological confirmation that they do have GCA, and that supports them being on steroids long term. Steroids come with significant risks, so if you can avoid keeping on someone on that medication for that long, you really want to. And when the histology comes back, and I've had consultants quiz me on what histology comes back on these samples, you can tell them that essentially you are finding giant cells deposited in the intima of the vessel and loads more lymphocytes than you normally would have, and that the vessel lumen appears extremely, extremely constricted because that artery is becoming very, very stiff and full with inflammation. So these are the things that were generally reported. Okay, going on to papilloedema. So papilloedema, that's specifically referring to optic nerve head swelling, which is secondary to raised intracranial pressure. If someone has optic nerve head swelling but doesn't have raised intracranial pressure, that's just known as disc swelling. And papilloedema, it's usually always bilateral, but it can be asymmetrical. There's different grading systems for papilloedema, which I won't go into today, but generally the things that you're looking for, you can see here, is elevation of the optic disc. You've got blurred disc margins, swelling of the optic nerve head, hyperemia as well. You've got flame hemorrhages, and you can see exudates. So this is a much more severe form of papilloedema than this one. And when you find this, a patient has a space-occupying lesion until proven otherwise. So they need to be sent for CT, MRI straight away. So one of the big things that they like testing on and comes up all the time is idiopathic intracranial hypertension. And it's really important to remember that this is a diagnosis of exclusion. So you've got the presence of raised intracranial pressure, but there's no cause. There's no intracranial mass, and there's no enlargement of the ventricles on MRI. 90% of these patients who come to you, they'll be women of childbearing age who are overweight and amenorrheic. It's really important to take an extremely good drug history. One patient came to the acute medical unit and was seen by lots of juniors and then I think 2 or 3 registrars. She was complaining of headaches and migraines, and she was extremely sick. She kept being told she had migraine, but I think her clinical presentation was so severe that no one wanted to discharge her. And it wasn't until my registrar went to see her and asked her about her drug history that he found out she was on tetracyclines, and this can actually cause raised intracranial pressure and give you papilloedema. So it's just really important to take a thorough history. So the signs, someone will present with just the general signs of RIP, headaches, worse in the morning, worse when you bend over. They can be nauseous, they can vomit, and they can complain of visual obscurations. So what we mean by visual obscuration is a transient sort of greying or blacking out of vision, which only lasts for seconds and then returns back to normal. And these patients will be investigated with an MRI, a lumbar puncture and the opening pressure will be above 210. That's just something to remember for exams. And you generally want to treat them with IV acetazolamide, so a carbonic anhydrase inhibitor. And they'll be regularly seen by opthal to manage their treatment. If they're not managed appropriately with drugs, then they can have surgical procedures. One of them is an optic nerve sheath fenestration. So it just blows my mind. They'll make tiny slits in the optic nerve to allow some of the cerebrospinal fluid to flow out. So if you remember, the optic nerve is covered in dura mater, and then you've got the CSF within the subarachnoid space. They'll make little cuts in the optic nerve so that the CSF can flow out and the pressure is reduced. Okay, so we've talked about the optic nerve subdivisions, how long they are and where they travel. We've talked about how to examine optic nerve dysfunction, so checking colour vision, checking contrast, brightness, contrast, sensitivity. We've looked at optic atrophy, primary and secondary. We've mentioned some of the causes. So for primary optic atrophy, you're thinking, could it be a tumour? Could it be something hereditary? Is it a nutritional deficiency? Or is it retrobulbar neuritis? For secondary optic atrophy, you're thinking about chronic papilloedema, you're thinking about ischemia, specifically arteritic ischemia, and also papillitis. And just to repeat, papillitis is inflammation of the optic nerve head itself. And then we've talked about optic neuritis and how we can subdivide the causes, so they can be demyelinating, infectious, parainfectious, or autoimmune. And we've mentioned some of the causes for those as well. Remember, the most common cause is demyelinating, and you want to be thinking multiple sclerosis. We've also talked about giant cell arteritis, which is a medical emergency. Those patients need steroids and they need urgent referral to opthal for a temporal artery biopsy. Okay, so, okay, I'm running behind. We'll talk about cranial nerve palsies now. Let's get going. Okay, so we'll start off by talking about cranial nerve III palsy, so an oculomotor nerve palsy. I'm sorry that the resolution of the photo isn't that good, but I hope you can kind of make out what's what. So with this lady, she's got a right-sided full ptosis. That's because oculomotor nerve, it innervates the levator palpebrae. Oh no, I wrote the wrong. Did I write the wrong? No, that's right. It innervates levator palpebrae muscle, so she's got complete ptosis of the lid there. When you open the eye forcefully, you can see that it's in an outward position, and that's because you've got unopposed action of the abducens nerve. So remember that lateral rectus is innervated by cranial nerve 6, not by cranial nerve 3. So you'll get unopposed action of the lateral rectus muscle. Medial rectus is supplied by oculomotor nerve, so there's no opposing action there. When you ask the patient to look medially to adduct the affected eye, they're not going to be able to do so because medial rectus isn't working. So you can see here that the patient can't move their eye inwards. When we ask them to depress the eye, they've got weakened depression because they don't have the full action of inferior rectus. On looking up, they've got weakness of upward gaze because superior rectus and inferior oblique aren't being innervated. However, when they're asked to look laterally, they can move their eye laterally because the abducens nerve is still supplying the lateral rectus muscle. So just remember, in the primary gaze, you're going to have what's known as the down and out position. So you'll have unopposed action of lateral rectus causing outward deviation. And then you've got the superior oblique muscle causing the down position. I know it's not greatly seen here, but superior oblique acts to turn the eye in and down. So you've got a downwards pull of the superior oblique muscle, which causes that outward position. So I've included this table because I just found it quite useful. But you can see here, superior oblique causes incyclotorsion or just intorsion. So that's turning the eye in and down. It has a secondary action of depression and also has a very small part in abduction. But you can see here that it basically does the opposite to inferior oblique. So there's no opposing action from inferior oblique acting. So the superior oblique actions will predominate, so it will act to turn the eye downwards. And this is just another example that you can work through of a third nerve palsy, showing the different weaknesses. Now the causes, depending on where the lesion is, the causes differ. So one of them is a posterior communicating artery aneurysm, and this typically presents very acutely and it's very, very painful. The reason why it's a PCA aneurysm is because you've got your third nerve just going along there. So if you've got an aneurysm, you can compress the nerve. Head trauma as well. So if you've got an extradural or a subdural hematoma and you've got pressure building up within the brain, it can squish the nerve and interrupt the supply. Diabetes, a vascular palsy, that can be pupil sparing. So I didn't mention it. Probably see it better on this one, that with a third nerve palsy, you get interruption of the parasympathetic nerve supply. So you have a dilated pupil, which you can see here. This guy's pupil is more dilated than this one. But with vascular palsies, they can spare the pupil. I can try and explain that at the end if you want, but I'm just around one time. Also pituitary apoplexy, so that's an hemorrhagic infarction of the pituitary gland. If I take you through here, so here we've got the pituitary gland. This is the cavernous sinus within the brain. If the pituitary gland has an hemorrhagic infarction, it can extend laterally and it can compress the oculomotor nerve. And you can see that the oculomotor nerve is quite closely related to cranial nerve, the trochlear nerve. So sometimes if you've got a problem here, you also have a problem here. And if you've got an aneurysm here, you can also have problems with the abductor nerve. So it's quite rare to get an isolated third nerve palsy just because of how closely everything is related. Yeah, an intercavernous pathology. So that's any pathology within the cavernous sinus where the oculomotor nerve is travelling. It could be a meningioma, it could be any type of inflammation within the tissues of the cavernous sinus. So a big one is Tulsa-Hunt syndrome, which is just, I think, an idiopathic inflammatory syndrome. You could have trauma, fractures, anything that happens within this cavernous sinus can cause problems with the oculomotor nerve. Okay, so moving on to a sixth nerve palsy now. This one's kind of nice and easy to understand. Sixth nerve palsy, you're not getting innervation to lateral rectus. So you can see here that this gentleman, on primary gaze, his eye is turned medially because you've got unopposed action of the medial rectus muscle. So you can describe that as an esotropia. If the lesion's on the right side, which it is, you'll have a right esotropia. When you ask the man to abduct his eye or to move it laterally, you can see that this eye can move to the right, but this one can't because lateral rectus isn't working. However, adduction is normal. Now, generally, the patient will have this compensatory face turn to the field of action of the paralyzed muscle. So this gentleman, when you come to see him, he'll have his head slightly turned laterally. And that's because he wants to move his eye into the field of action of lateral rectus to reduce double vision. Okay. So talking about causes of sixth nerve palsies, you can see here that the abducens nerve nucleus here is very closely associated to the facial nucleus and the facial nerve. So if you've got any problem with the nucleus of the abducens nerve, it's not going to be isolated. It's going to affect the facial nerve, and the patient might have a facial nerve palsy. So if you've got someone with an isolated sixth nerve palsy, it's not going to be happening in the center of the brain. Acoustic neuromas, raised intracranial pressure, nasopharyngeal tumours, and basal skull fractures where the sixth nerve exits, they can cause palsies as well. And lots of conditions can also mimic sixth nerve palsy. So myasthenia, if you've got tired rectus muscles, you can mimic a sixth nerve palsy. Also restrictive myopathies or chronic thyroid eye disease. So if we talked about last week, I think, if someone's had inactive thyroid eye disease for a long time, they can get very stiff muscles. Okay, and now moving on to our fourth nerve palsy. So this is the only crossed cranial nerve. So the fourth nerve nucleus innervates the contralateral oblique muscle. So in the primary gaze of someone who's got a fourth nerve palsy, you're going to get hypertropia of the eye. So the eye is going to deviate upwards slightly. And that's because you've got an elevation of inferior oblique. So inferior oblique acts to elevate the eye as well as extort it. So you'll get an upwards deviation and also a very slight outwards deviation as well. On adduction, the hypertropia worsens because you get an overaction of the inferior oblique muscle. And you also get limitation of depression in abduction because the superior oblique is weak. Again, we've got this table here that you can work through. I find it really useful to look at which movements the eye muscles are being unopposed with. Okay, and the compensatory head tilt that will happen is the patient will tilt away from the lesion. So if she's got a right fourth cranial nerve palsy, if she tilts her head to the right side, the hypertropia worsens and the double vision worsens. But if she tilts to the opposite side of the lesion, she can balance out that motion and the double vision reduces. Okay, so cranial nerve 7. So thinking about what it does if you've got a palsy. So it innervates frontalis. So frontalis works to lift your eyebrows. So if you lose that innervation, you can't wiggle your eyebrows. You don't get the wrinkling of the forehead. And it also innervates auricularis oculi. So these patients will have problems bringing their lids together. So they'll have what's known as lagophthalmos. They don't have full closure of their lids. They might have a paralytic lower lid ectropion. If you look, that's where orbicularis is. So they can't move their eyelids together. That lid sinks down. They can have an ectropion. You've got buccal branches which innervate the orbicularis oris muscle. So if you don't have innervation there, you'll get the classic droopy mouth as well. So these patients, you can see on this lady, she's got a right-sided facial palsy. She can't raise the eyebrows to wrinkle her forehead. She's got a drooping mouth. You can see here she's got a very slight ectropion and her eye's very red. So these patients, they're very high risk of dry eye and exposure keratitis. So one thing you need to do when they come to clinic is check their Bell's phenomenon. So what you'll do is you'll ask them to close their eye. Obviously they'll have problems doing that, and you'll watch to see if their eye rolls upwards. If their eye rolls up and their cornea is covered, you know that they'll be safe to sleep at night without risk of their cornea drying out, because their cornea will be rolled up and protected. But if they don't have an adequate Bell's phenomenon, these patients, you'll need to ask them to take their eye at night, and they'll need to use a lot of lubricating drops. Ointments and gels were quite nice to put in at night because they can blur your vision. And an important thing to note is how to differentiate your your upper motor neuron causes and lower motor neuron causes for a facial nerve palsy. So as you can see from the diagram here, the upper muscles, upper facial muscles have bicortical innervation, but the lower facial muscles only get innervation from one side of the brain. So if you've got an upper motor neuron lesion or you have a stroke here, you will get innervation to the upper muscles from the other side of the brain. So you'll still be able to wrinkle your forehead. You'll still have supply to frontalis, so you can still wiggle your eyebrows. But if you've got a lower motor neuron lesion, you lose innervation to both the upper and the lower muscles because you don't get transfer of the bilateral innervation. So in a patient with a lower motor neuron lesion or a Bell's palsy, they'll lose complete muscle function on one side. But if the patient's had a stroke, they will be able to retain this function. They'll be able to wiggle their foreheads. Okay, and that's what we've just had a look at. So the visual pathway in lesions, this is really important to remember. Unfortunately, it's something you just have to memorize. And if any of you attended Yaro's lecture, the first one, he's got a really nice slide, a couple of slides actually on the visual pathway and corresponding lesions. So I'll just direct you to that because it's just really important to remember. And now we'll talk very briefly. This is the last slide. I know we've overrun quite a lot. Apologies for that. But we'll talk about double vision. You might want to grab a pen and a paper because I haven't written all of this down for you. But diplopia can be divided into monocular or binocular. So when you're thinking about monocular, it's diplopia that persists when a patient closes one eye. So it will still occur when they've closed either eye. And that's usually referring to ocular disease. So they might have a cataract or a refractive problem. So they could have corneal surface irregularities. They might have a pterygium growing across their eye. It could be post-cataract. Perhaps they've got capsule opacification at the back of the eye. And it should resolve when you do the pinhole test on them. So the pinhole test acts to direct light rays into the center of the eye. So it gets rid of all the blurred rays and focuses the light rays. And that should act to resolve the monocular diplopia. So monocular causes, you're thinking corneal surface irregularities, cataracts. They are ocular problems or refractive problems, and they resolve with a pinhole. Now, binocular causes is diplopia that resolves when patient closes either eye, and it's referring to ocular misalignment. So that could be referring to extraocular muscle dysfunction, and that could be because they've got a myopathy, they've got restriction of muscle movement, or there's an orbital inflammatory process affecting the muscles and how they move. You could have problems at the neuromuscular junction, such as in myasthenia gravis, which means that the eyes can't move together symmetrically. It could be cranial nerve palsies. So we talked about 3, 4, and 6. That affects how the eyes move symmetrically together. Or it could be supranuclear, and we won't get into those causes, but those are talking about your gaze paresis and your internuclear ophthalmoplegia. So just to quickly go over that again, you've got diplopia, which can be divided into monocular and binocular causes. Monocular diplopia will persist when the patient closes one eye. It refers to ocular surface diseases, so corneal surface irregularities, stigmatism, cataracts, pterygium, and it resolves when you use a pinhole. Binocular causes are talking about ocular muscle misalignment. So the extraocular muscles aren't functioning properly, They're either restricted, inflamed, there's a myopathy there, there's a problem at the neuromuscular junction, perhaps myasthenia gravis, it's a cranial nerve palsy, or it's a supranuclear lesion.